Good morning, good afternoon, everybody. This is our second podcast for the Scleroderma Forum. It's a very important one today. We have the honor of having an external member of the Scleroderma community. It's Professor Ed Vital. He's Professor of Translational Medicine, University of Leeds, and he's a wealth of experience in lupus, of course, and even before that in B-cell targeting strategies. Thank you, Ed, for coming.
Hi, thanks for inviting me.
So, Ed, just to give you a bit of context of why we're even considering cellular therapies in scleroderma, this that you see here is a summary of some of the mechanisms that are known to be involved in the pathogenesis of scleroderma. And very similar to what you know in lupus, there is here you see on the left this mitochondrial damage or other sort of DNA damage in the cell that eventually leads to innate immune activation and priming of adaptive T-cell response. Now, why this is so very similar to lupus, why this is leading to fibrosis in scleroderma to inflammation in lupus is one of the topics not for today. But in this context, yeah, T-cell activation and priming may happen in the tissue, and you are one of the promoter of this notion, yeah, that it's not the immune system, is the tissue that is driving the immune system.
Yeah, like in lupus, the rationale for why to target B cells is just like pretty obvious, really, isn't it? We all see in our clinics autoantibodies, immune complexes, complement consumption, all of it's really it was an obvious move, and that's why B cell targeted therapies were brought into lupus so early. But yeah, as you say, what's important and maybe not quite so obvious is that there might be something upstream of that. The problem
Correct.
might not start from the B cell, and that's pretty important concept for what we're talking about today, isn't it?
Yeah, not only, yeah, absolutely. So, so the role of B cells in sustaining a T cell response, but also there's been very interesting recent literature showing that autoantibodies in scleroderma may be directly linked to the type of damage. And so reports of anti-topoisomerase antibodies penetrating the cells, very recently anti-mitochondrial antibodies going and sustain this damage. So that's what has built a rationale. Part of the rationale was borrowing a drug in a disease where there is no effective treatment. You take treatments effective somewhere else. And actually, the classic old one, rituximab, it's in the Euro recommendations because there is evidence for both of skin and lung. But then why to go from a drug that works like rituximab in depleting B cells into a cellular therapies is what I would like to discuss today. What is the rationale? What you have learned? What are you learning in lupus? What do we need to know when we need to make our call or to design our trials?
Yeah. Okay. So this is, as you know, a subject that's kind of pretty close to my heart because of everything I did from my PhD onwards, really, which so it's 20 years now. So when we first used rituximab, people said the same things they say about cellular therapies now. You deplete B cells completely, you reset the immune system, they come back and they're not autoreactive anymore. It was exactly the same concept. But initially it seemed like rituximab kills all the B cells, but people only sometimes respond. And we couldn't understand why. And so that was really what I did in my PhD, which was we developed at the time very novel flow cytometry protocols. I mean, it's a bit more standard in these days, but at the time, if you improved your flow cytometry protocol so you could measure plasmablasts, then you actually found that depletion was more variable than you thought. And the thing is about plasmablasts, it's the plasmablasts are when B cells are trying to turn into plasma cells. And it's this intermediate stage that only lasts for a few days when they're flying around the blood, maybe going from the lymph node to the bone.
I think that's a very important, yeah.
If you still see them, then if you still see them about, it means there's something going on outside the blood, basically.
So that's a key concept, because people involved in scleroderma, also scleroderma expert, may not be so familiar with B cell biology and what is the relation between a B cell and a plasma cell, more or less. I think it's well known, but this plasmablast state, it's something that is
Yeah.
not very commonly
Yeah.
read.
So yeah, exactly. So basically, the way I say it is B cells are the ones making the decisions, what should be targeted and what shouldn't, and plasma cells are the ones making the antibodies long term. And the plasmablast is just this intermediate stage when they traffic from one place to another. So they go around in the blood. If they find a niche in the bone marrow, then they turn into a plasma cell and sit there and make antibodies long term. If they
And this
don't
one,
find that niche, they just die.
exact, and they have different cellular and membrane markers, this plasmablast. So some
Yeah.
therapy that can be very effective on B cells, the plasmablasts that are currently in this circulation may be completely immune or or
Yeah.
safe from it.
Right. So this, and that's something we're going to talk about a bit more in a bit later on, isn't it? The different why the different surface markers might be important. Yeah.
Yeah. Okay. Thank you. So when you were doing that, you discovered basically that that it was not all or nothing, this immune.
Yeah. So then what we found later on was that the reason why rituximab doesn't kill the B cells completely isn't just something like the dose of the drug. It's something more to do with the effector mechanism. Now, basically, when rituximab binds to CD20 on a B cell, that doesn't actually kill the B cell. That just labels it. That just says this is something to be targeted. What kills the B cell is when effector cells come in, NK cells typically, or monocytes. They come in, they have Fc gamma receptors. The Fc gamma receptor recognizes the Fc part of the rituximab molecule and it kills the B cell. And what we showed that that was important because actually you've got genetic polymorphisms of these molecules of the Fc gamma receptor. And if you've got a variety that's better at binding B cells, then that was associated with better B cell killing and clinical response. So it's all about the effector cell that makes the difference.
Yeah, that makes entirely sense. And then there was a lot more after that, right? You started to measure clinical response based on this heterogeneity.
Yeah, that's right. Yeah. So the plasmablast numbers associate with how much your autoantibodies go down, like your double-stranded DNA, how much your clinical response does, and the Fc gamma receptor genotype associates with the plasmablast numbers and with the clinical response as well. So it all seems quite a nice logical story, and a lot of that has also been shown in the original B cell targeting diseases of lymphoma as well. So
Yeah, yeah. Good. Yeah, so this makes entirely sense. So this rationale is translatable in scleroderma because of the role of B cells, as I mentioned. But I think we can learn a lot from a type of antibody-mediated damage, and before that, what is the role of different
yeah.
targets that we can do?
Basically, based on that understanding, there are some different approaches to try and improve the B cell killing to get it to work better. So one of them is make a better antibody. So, for example, you can modify your monoclonal antibody to make it bind Fc gamma receptor better or to kill B cells in different ways. And this is what obinutuzumab does. So it's like glycoengineered, so it's better binding to the Fc gamma receptor, overcomes those genetic variations, and it also can kill B cells directly by itself. It doesn't have to, it can even do it without an effector cell. So obinutuzumab does that for CD20. Ianalumab has a similar mechanism, but a different surface marker. Actually, it targets BAFF receptor. So that's the sort of the monoclonal antibody method.
Oh, and can you touch on that? Because of course there are clinical trials. Scleroderma is often coming a few years after lupus,
Oh yeah, good
and
point.
you
Yeah.
have the type 1 interferon receptor antibody has been approved when it is in phase 3 for scleroderma. You have Benlysta, and that is in phase 3 for scleroderma. Why buff?
So yes, so right, so that's a good. So obinutuzumab is actually succeeded in phase 3 in lupus nephritis with a trial in non-renal lupus in progress. So we're pretty sure that works and works better than rituximab. Then the other one that I mentioned is ianalumab, very interesting molecule. So B cells rely on this survival signal, which is something called BAF, also called BLIS. BAF means B cell activating factor, and BLIS means B lymphocyte stimulator, but it's just the same. It's the same thing. So basically, without that, B cells can't mature, differentiate, do all that what we talked about, differentiating to plasmablasts, to plasma cells. And so if you don't have BAF, B cell number, basically if you have a mouse where BAF's knocked out, then you only get transitional naive early B cells coming out of bone marrow. They never fully mature. So blocking BAF is one way to target B cells instead of killing them, which is what Benlysta or belimumab does, and some follow-on drugs too. So what ianalumab does is really interesting because B cells have this BAF receptor on them, and what ianalumab does is it targets the BAF receptor, but it actually kills the B cell. So if ianalumab binds to the BAF receptor on a B cell and you've got, say, NK cells around, then that'll kill the B cell. But if ianalumab targets the BAF receptor and maybe, I don't know, maybe the B cell didn't die or you didn't have a good enough effector cell around or something, then it doesn't kill the B cell, but it still starves it of BAF.
Yeah, so it prevents it from the life signal. So it prevents it from the survival signal. Great. So these are the two strategies. And and then you wanted to discuss about this now, how we can make it better. How do we place now in this context? We have these monoclonal antibodies. Good, they're doing their job. We can make them more specific against why cell therapies.
Yeah, so I mean, this really comes, I mean, again, you say scleroderma is following from lupus, but lupus is following from hematology. So in hematology, obviously, this issue of depth of depletion is super important. You do not want to leave malignant cells behind. So they've tried a lot of these strategies in the past. That's where obinutuzumab came from. And they've found something that works even better than that for killing, which is cellular therapy. So you've got two ideas here. One is CAR T therapy. So that's what you do. So the idea here is you actually, instead of giving a monoclonal antibody and hoping that the effector cells will take over, you actually give an effector cell. So what you do is you take the patient, you do a lymphodepletion, you take their blood, you take their T cells, you reprogram their surface T cell receptor, so that instead of targeting some foreign antigen, they actually target CD19, a B cell marker, or some other B cell marker. You give them back to the patient. And so then their own T cells are going around their body, finding their own B cells and killing them. And basically, T cells are just much better at it than giving monoclonal. So particularly, they can go into tissues. So if you've got like a lymphoma or a leukemia or something, a lot of your problem is within lymph nodes, and CAR T cells can go into lymph nodes and kill much better. And they really do a very effective killing in tissues. Now, that comes with some challenges, costs, difficulties. It's a complex approach. So then the other approach that has been developed has been to use something called a bispecific T cell engager. So this is a clever trick, which is make a monoclonal antibody that's got two ends to it. So one side of the monoclonal antibody targets your B cell antigen, say it's CD19, the other, or CD20 or whatever, but the other side of it targets CD3 on the T cell. So basically you just give a monoclonal antibody and it brings the B cell and T cell together inside the blood.
So it increases the effector part.
Easier. It's a lot easier to give. I think at least what we know from hematology is the CAR T is the really, really potent one, but the T cell engager may be like somewhere in between monoclonal antibodies and CAR T, like for effectiveness.
Yeah. And of course, with the T cell engager, you don't need the actual cellular manipulation, right? It's like giving a monoclonal.
It's just like giving a drug, yeah.
And then we will discuss the implication and safety of all of those. So now we will not discuss the results of the preliminary studies happening in scleroderma. We'll have that with the PI running them. But with you, I would like to focus a bit on. So thank you, first of all, because I hope this puts a bit in context the biology or where these are coming from.
Yeah.
And what if you have to summarize your results, what you have seen so far in lupus, what have you seen?
Yeah, so I think we can say that so with rituximab, as very famous within the world of lupus is everyone thought it would work, but the trials were actually negative. Some of that might have just been that we didn't know how to do lupus trials back then. That is obviously partly true, but then partly, so in the clinic, I use rituximab all the time, as you do. We find it really, really useful, but we are conscious that the efficacy isn't 100%. I think from what I've seen, obinutuzumab has positive trials because maybe that's just doing better trials and measuring the effect more accurately. But I do think it's a really different drug. I mean, when I do flow cytometry, you can see the difference between rituximab depletion and obinutuzumab depletion. Ianalumab earlier stage of development, but the phase 2 did look good. Did look very strong. So that all seems quite positive that these more modern approaches do work better. Now, when it comes to CAR Ts and BiTEs, I think the evidence that they kill more B cells more effectively is pretty good. So we've got things like biopsies of lymph nodes showing the depletion is better with a CAR T cell therapy in lupus than with a monoclonal antibody therapy. So I think that part it's all small numbers, but it looks pretty striking. The efficacy part, it's intriguing, and but I think everyone would agree that we need more data. So we've got these case series where what they report seems really amazing. So people like all the patients getting complete remission, coming off other therapies and staying in remission for somewhere like it must be, and they used to say 18 months, it must be about 2 years or maybe a bit more of follow-up now of people
Yeah.
in remission. So
And that actually that leads me exactly to the question I had for you. I remember the first case reports of rituximab. They had the same vibe. They
yeah,
had the same vibe of, oh wow, we reset, that's it, done, once and for all. Whereas then we learned, and without too much without thinking too much, to repeat rituximab every now and then. So this leads me to the critical question, because this is a very hot topic now in these scleroderma trials, where the case series shows as brilliant effects as the one that you have mentioned in lupus, but they are case reports. And so there are some trials that are cleverly designed. That is and because now we have two different topics here in scleroderma. One is there is a new technology to develop CAR T. Do these CAR Ts developed this way have the efficacy that we know? And those are phase 1b trials, if you want, right? But then the crucial question is what's happening afterwards? What is the optimal clinical trial to place this intervention in a therapeutic pathway? Yeah. Once we have an effective drug, or in this case, an effective intervention, when do I give it? How does it fare compared to the other ones I have? How are you guys sorting this out in lupus?
yeah. Well, I mean, I wish I had all the answers to that, but I think you could definitely say that these are really becoming really, really interesting questions. So, firstly, I guess, like you say, deeper depletion, better response. I don't have too much of a problem with that because I think there's so much evidence to suggest that. So, yeah, the idea that if we have a therapy that kills B cells better, that'll lead to a better clinical response. I think we only have case series, but I think that'll turn out to be correct. Yeah. So, does that reset the immune system? Well, there things I think are a little bit more complicated because it's a bit like this is going back to what we said at the start, right? Which is in lymphoma or leukemia, the whole disease started because one B cell got a mutation and became malignant, and it all started from there. And therefore, if you eliminate every single last malignant cell, disease is gone, won't come back. That's clear. But like we both said, in lupus, in scleroderma, the B cells didn't just go wrong by themselves. There was something, at least this is what I believe, and I think you believe too. There's something upstream of it that made them go wrong.
Yeah.
And
yeah, and so in theory they could come back. It's interesting you use the word reset. One of the trials that is currently ongoing is called Reset SSC for this reason, right? And the evidence showing that naive B cells are the one coming back is supportive. Now, what we don't know in
the other thing I was going to say is, so you might say that, like, if the innate immune system drove the B cells to be abnormal, then the disease is going to recur. But there's an argument against that as well, which is saying that won't happen, which is it takes years to get lupus. You've been antibody positive for years. And of all the people who are antibody positive, a tiny of ANA positive people, basically, it's 5% of adults. So a tiny number of them actually go all the way to develop lupus. So can we take you far enough back down that path that maybe getting a lupus again, maybe you will get lupus again, but it's going to take 10 years.
Exactly.
And maybe only a small fraction of people will go all the way again. So there isn't a possibility of reset. And this is, I think, one of the most profound questions of our time in autoimmunity, really.
Yeah. And this is actually exactly what we were discussing. We're discussing this concept of reset, because in scleroderma is the same. We have identified this very early stage where people have Raynaud, they have some capillaroscopy changes, and they have the scleroderma antibodies, yeah? The one that we know, and they might have some others that we don't know. And they take 4 to 9 years to start to have a clinically significant sign. So if a reset therapy would bring me back a patient to the VEDO stage, I will welcome it.
They might stay there. They might. Firstly, that might be enough. If I'm going to get lupus again, but it's going to take 5 to 10 years,
fine,
I'll take that. Yeah, I'll take that deal. And the second thing is, you might not progress all the way again. So then you really yeah.
Do you think, in this sense, do you think we can use because some of these case reports show that there is a negativization of the autoantibodies. Do you think we can use, these are still the best biomarkers we have, both in lupus and in scleroderma.
That's
Do you
right.
think we can use redetection of autoantibodies as a biomarkers of something is brewing back?
That's a really important point. Yeah. So if you take lupus, when you give rituximab, obinutuzumab or something, like, usually the double-stranded DNA goes down, often to negative, and the complement levels improve. But other autoantibodies very rarely become negative with rituximab or obinutuzumab. When you use CAR T therapy, the report is that most autoantibodies became negative. The one exception being Rho or SSA, but most of the other autoantibodies all became negative. That's a very striking difference. Why is that? So is it just because it's a more effective cell killer? It could be, but the other reason could be that actually rituximab and obinutuzumab target CD20, whereas CAR Ts that have been used target CD19. And CD19 goes a little bit broader into, so plasmablasts have CD19. I mean, they only live a few days anyway, so it's not important to kill them directly. But some plasma cells still have CD19. Basically, they keep it if they're a shorter-lived plasma cell. The longer-lived ones lose the CD19 completely. So that CAR T is depleting some plasma cells too. And maybe that's why it helps make antibodies negative, which could be one reason why it's more effective. It's not just the cellular killing. It's also a different target.
Yeah, no, it makes entirely sense. So yeah, so these are the milestones to see.
And just to continue that point is the other thing. This again comes from hematology, where if they want to treat myeloma, they definitely have to target plasma cells. And if you want to do that, even CD19 is not good enough. Actually, what you have to target is a molecule called BCMA. BCMA is another one of the BAFF receptors, but it's the one that plasma cells express.
And yeah, we've seen And we have seen in the pipelines of people these bites with BCMA and things. Very good. So it is. I think it's clear also for the audience what we think are the milestones. But there is one thing we didn't discuss. You're right. We use a lot of rituximab in clinic, and we are ready for something that works, but not every time. But what we do know is that it's a safe drug, and the safety it's quite acceptable. Now,
Yeah.
together with this brilliant clinical response, we are also seeing signals of toxicity and sometimes important toxicity. What do you think of that?
Yeah, that's right. So these are important things to think about. So with CAR T therapy, um, there's a couple of well-known side effects that are kind of unique to that therapy. So one of them is a cytokine release syndrome. This is a little bit like you can get it with rituximab and obinutuzumab, but it's on a bigger scale, which is basically if you set off a load of T cells and give them their target, you're starting a fire in the immune system. So then you get tons and tons of inflammation, and that inflammation can lead to a pretty severe systemic illness, which they call cytokine release syndrome. It has different grades, but at its more severe end, it's the person is pretty sick in a sort of sepsis-like way with severe inflammation. You can treat that with tocilizumab, which is what we normally do. So if you're doing a CAR T trial, you also have to be standing by with tocilizumab. And I think actually the hematologists have become very experienced at managing that. So it's less of a worry, but you do have to be ready for it. Now that is probably less of an issue in autoimmunity than in malignancy, because in hematology they've got too many B cells because they've got a malignancy, thousands more than there should be, and so there's more inflammation. Autoimmunity, actually B cell numbers are actually a bit lower than a healthy person, and so there's less. That's probably less of an issue. It doesn't really seem to occur. The other one's called ICANS, which is this neurological syndrome.
Yeah.
And now that's a little bit less, again, it's probably more of an issue in hematology than it is in autoimmunity, but it may be a bit less predictable, I think. So they get a variety of strange neurological symptoms. If you just monitor them doing their handwriting, sometimes you can see that change as one of the most subtle signs, but that can progress to much more marked neurological symptoms where difficulties in movement and even like, pretty bad brain inflammation causing seizures and comas and things. So again, it doesn't appear to happen as much in autoimmunity from what we know so far. There's one, I think there might be one quite significant case, but apart from that, it hasn't really been seen. But it's a bit less predictable and difficult to manage. So these are important things to be aware of.
Absolutely, absolutely. And a few of these trials I've seen, we used to do skin biopsies in scleroderma to measure biological response. Well, now I see in the protocols they do lymph node biopsies just to have a proof of biological response. Is there any experience with that in lupus?
Yes, that has been there. That's been shown in autoimmunity too. So there's a paper, is it this year or maybe end of last year in Annals, I think, from the Erlangen group who've published the most on this area, where they gave some really nice examples of lymph nodes, and it's the difference in depletion between rituximab and CAR T looks absolutely night and day from what you see there, which is what the hematologists would have predicted too. So I think that's.
Yeah. So we really look forward to see the results and see how deep is this reset and for how long it lasts.
Of course, you might question what the correct tissue to deplete is. I mean, I would. I don't know what you think of scleroderma, but in lupus, I think that that's not a complete given, because in lupus, we talk about extrafollicular activation of B cells via TLR7, and then you get these double negative B cells. So that might be outside the lymph node. And we also, you think about, well, do you have to deplete the B cells that are like, say, in the kidney if you've got nephritis? Well, I don't know, because B cells are making immune complexes that are going around in the circulation, so they may not have to.
No, you're right. I think as it always. Yeah, I think as it always happens, there is so many biological questions that will come if clinically we become convinced that this is valuable, then we will refine a lot after that.
Yeah.
Well, this has been very useful for me, and I hope it's been very useful for the audience. Thank you so much, Ed, for your time. And to the people that are seeing this podcast, please subscribe to this podcast. You find it, besides through the link, you can find it on Spotify, on iTunes, or other podcast media. And above all, we are new to this and we're trying to disseminate knowledge, and let us know what you think. Give us feedback, because so we can refine and do better. You can also watch us on Scleroderma Forum and on YouTube. And subscribe also to X and LinkedIn so that you will know when these are coming out. There are few more planned for 2025. Thank you again, Ed, and thank you
Thanks.
for listening. And we'll talk again.